talk I'm going to give today is entitled Diagnosing Mild Cognitive Impairment. And in this talk, I will try to give you an overview of mild cognitive impairment. I will talk a bit about the history of the concept of MCI and some of the controversies that have been through the time about the concept of mild cognitive impairment. And then I'll talk about why mild cognitive impairment remains important and how to diagnose mild cognitive impairment. I would like to start my historical part of my talk about MCI in 1984 when the first clinical criteria for Alzheimer's disease were published. Now, there are a number of features about these criteria that are interesting to look at when we talk about mild cognitive impairment. Now, firstly, these criteria were for Alzheimer's disease, and in this criteria, the Alzheimer's disease was defined by the presence of dementia. So a patient had to have dementia in order to be diagnosed with Alzheimer's disease, and also had to have impairments in two areas of cognition, of which one had to be memory. Also, the diagnosis of Alzheimer's disease was a diagnosis of exclusion. So Alzheimer's disease was defined as a disease with an insidious onset and slow progression, with deficits in memory and one other cognitive domain. But in order to give the diagnosis, all other causes that could give a similar clinical picture had to be excluded. So we could try to construct a model of Alzheimer's disease based on these diagnostic criteria. And as I said, Alzheimer's disease was defined by the presence of dementia at that time. Taking this to the extreme meant that if you do not have dementia, the patient does not have Alzheimer's disease. And taking it even further means that the patient is in the spectrum of normal aging. The authors of the criteria from 1984 were well aware that this model does not hold true, but they did not feel comfortable going beyond defining Alzheimer's disease beyond the dementia stage. But clearly there's a transitional state between not having dementia and cognitive and being in the normal age spectrum and having dementia, and it was this transitional state that mild cognitive impairment was supposed to cover, so to speak. And of course, this idea of the threshold of symptoms being a criterion for disease is not something that we see in other types of neurodegenerative disorders, such as, for example, Parkinson's disease, where it is the presence of bradykinesia, tremor, and so forth that defines the disease and not the severity of, for example, bradykinesia. And of course, also in the criteria was this idea of this the fact that Alzheimer's disease is a slowly progressive disease, and this is of course not only true in the dementia state, but also in pre-dementia state. And finally, this model also fits very nicely with what we know about the pathology and the pathological lesions that these accumulate over many years in Alzheimer's disease and other neurodegenerative disorders. And with accumulating pathological lesions, we see more and more severe symptoms. The term mild cognitive impairment was coined in the 1980s, but really more clearly defined in the mid-1990s with the publication of the so-called Peterson criteria, where mild cognitive impairment was defined as a syndrome in which the patient or caregivers had complaints of memory problems. There was objectively measurable cognitive memory impairments, but general cognitive function was normal, and there was normal activities of daily living, so also no dementia. Now, this idea of a transitional state not only applies to Alzheimer's disease, but also other neurodegenerative disorders, which in general are slowly progressive, and clearly that there is some sort of a transitional state between normal aging and the dementia syndrome. There were a number of issues that were criticized in the beginning with the advent of the criteria for mild cognitive impairment. One was that it was focused on memory impairment and thereby did not really capture the clinical reality, and also was not relevant with regards to other dementia disorders in which memory impairment might only be slight or maybe not at all. And this criterion was true. This criticism was true. The initial criteria were focused on amnesia, on memory problems, but this was also because they were specifically designed to capture a pre-dementia state of Alzheimer's. So that made a lot of sense. But later on, the criteria were, or there were other diagnostic criteria developed for to capture other cognitive profiles in mild cognitive impairment, so multi-domain MCI and single-domain non-amnestic MCI. And these was, of course, also launched in order to try to develop pre-dementia models of other neurodegenerative disorders such as Lewy body dementia and frontotemporal dementia. The second point of criticism was that MCI is not stable in the sense that some patients diagnosed with MCI will progress, as was sort of the idea with the concept, but some will reverse back to normal condition and some will remain stable. On this slide, you see data from a number of observational epidemiological studies across the years in which a large number of patients with MCI were included into and followed. And here you see that the rate of reversion back to normal cognition, as well as the progression to dementia, varies greatly between studies, but also that some studies report a very high percentage reverting back to normal cognition, and other studies report a very high rate of progression to dementia. One of the reasons for this wide variety and variability in progression to dementia or reversion back to normal is that a lot of these epidemiological studies define MCI rather broadly and in a way that is not applicable in a clinical setting, and really capture a very heterogeneous group of patients with MCI, presumably with very different underlying conditions that causes the syndrome of MCI. And this highlights an important issue that diagnosing mild cognitive impairment is one thing, but the real important issue is to diagnose the underlying cause. This is also highlighted in a number of other studies. For example, here the authors look at the cognitive profile and risk of progression, and it's clear to see that different cognitive profiles are associated with different risk of progression to dementia, as well as reversion back to normal cognition. A second study looked at the risk of reversion back to normal cognition and whether or not patients were recruited from a clinic or in a community. And here you see that being recruited from a clinic is associated with a lower risk of a reversion back to normal, whereas progression to dementia is higher in those patients that are recruited in a clinic. And we also know other factors in patients with MCI that are associated with different rates of progression or reversion, such as depression, age, gender, and education. So it might be difficult to say that MCI is not stable, because MCI is a syndrome, and what tells us about whether the patient will progress, reverse, or remain stable is really the underlying cause of the syndrome of mild cognitive impairment, and that is what the diagnostic challenge is, to find the underlying cause. So a patient with MCI due to depression is likely to revert, remain stable, whereas a patient with MCI due to AD is likely to progress. And I think taking another example from neurology, let's say headache, we would not normally stop by diagnosing that the patient suffers from headache. The diagnostic process would be directed towards what the cause of the headache is. What is the underlying headache disorder? Is it a subarachnoid headache, subarachnoid bleeding that gives the headache? Does the patient have migraine? Does the patient have a sinus vein thrombosis? Does the patient have tension type headache? And it's clear to see that in the instance of the headache, what is important to the patient and what will give the prognosis, what will determine the therapy, is of course the underlying headache disorder. And the same goes for MCI. So one way to look at it is that if we start with the diagnosis of MCI, this might be due to many different disorders, some of which will be associated with a high risk of progression, whereas other will be associated with a high risk of aversion or a low risk of progression. And I think sometimes this might be mixed up by saying that if we start by dementia due to Alzheimer's disease and look back, it's clear that those patients that will be diagnosed with Alzheimer's disease at the dementia state have gone through a stage of mild cognitive impairment. So in that sense, there's a one-to-one association with having dementia due to Alzheimer's disease. You will definitely have passed through a state of mild cognitive impairment that might have been diagnosed, but reversing this and saying if you have mild cognitive impairment, you will go on to develop Alzheimer's disease is far from the truth. And this also highlights the importance that we need to be able to prognose at the individual patient level. And there are a number of initiatives and research projects aimed at developing better individual prognostications, such as the BI project or the PredictMD project. Another thing that has helped to enable more accurate diagnosis of patients with mild cognitive impairment is the continued refinement of the diagnostic criteria for MCI. So I already briefly touched upon the criteria for multi-domain MCI and single-domain non-amnestic MCI as well as amnestic MCI. But over the last decade or so, we've seen a number of other diagnostic criteria for mild cognitive impairment, which has incorporated biomarkers to better reflect the underlying pathology. And this development has especially been with regards to Alzheimer's disease, but we're also starting to see criteria for a sort of mild cognitive impairment phase for Lewy body dementia, and there are also criteria for vascular mild cognitive impairment in the VASCOG statement criteria. But it's really with regards to Alzheimer's disease that we have seen this development of the criteria, and especially with the incorporation of biomarkers. And I just want to go through some of the criteria that have been published within the recent years. So on this slide, you at the top of the screen will see that we have the concept of mild cognitive impairment that might be very broad, and we've gone through these amnestic MCI and non-amnestic MCIs, and the fact that amnestic MCI was coined as a pre-dementia stage, specifically of with regards to Alzheimer's disease. And then we have the DSM-5 criteria, in which MCI is not called MCI, but it's called minor neurocognitive disorder. And we do not see any biomarkers apart from autosomal dominant genetic mutations in these criteria. Then there are the NIAAA criteria for MCI due to Alzheimer's disease, which incorporates to a high degree biomarkers, of course those that reflect Alzheimer pathology, that is beta amyloid and phosphorylated tau, as well as biomarkers that reflect downstream pathological events, so basically neurodegeneration, and that's MRI, FDG PET, and tau. And here there is 3 levels of certainty of the diagnosis: uncertain, intermediate, and high. And then we have the International Working Group criteria, where we have prodromal AD, where biomarkers for beta amyloid and tau are incorporated. And then lastly, we have the ATN research framework, where the diagnosis of MCI, of Alzheimer's disease has been totally disengaged from the clinical picture, the clinical symptoms. It is entirely based on biomarkers of amyloid pathology, of tau pathology, and neurodegeneration. And so here Alzheimer's disease is defined as a proteinopathy, you might say. Okay, so another criticism that might at times be raised with regards to diagnosing mild cognitive impairment is that it is unethical. Some might feel that diagnosing a uncurable disease with no disease-modifying therapy, which for most people is a very serious diagnosis, leads to unnecessary psychological stress. And also because at present it is difficult to say when patients will progress, even if we think they have Alzheimer's disease as a cause of their MCI syndrome. We are not able to give a very specific prognosis, and definitely not on the individual level. Some might also say that this is problematic. Well, I'd say that there are a number of arguments for the opposite side with regards to diagnosing MCI. So patients who seek out medical attention because of cognitive symptoms do it for a reason. They want to know what is going on. They are feeling something, and they want to know what is it that is happening with me. And people have a right to know. Of course, they also have a right not to know. But if they seek out a doctor, I would say that it's in most cases implicit that they would like to know. And they might have something that is treatable as a cause of their syndrome of MCI. And yes, we cannot cure or even offer any disease-modifying therapies for any of the neurodegenerative dementias, but that doesn't mean that we can't manage patients with MCI, even patients that have MCI due to Alzheimer's disease. Patients will also miss out on participation in drug trials and other research if they are not diagnosed, and a lot of patients do actually have a wish to participate in these trials, is my experience. I think it also empowers patients to get a diagnosis. They have the possibility to act. They have a possibility to change things in their lives that might help them. And if they have a neurodegenerative disorder, advanced directives and decisions about their future is maybe better planned in this early stage of the disease than in the dementia state. And finally, they also have the possibility to join support groups, for example. So how to diagnose MCI? Well, as I've touched upon numerous times in my talk already, I think it is not only diagnosing the syndrome of MCI. We cannot stop there. Our diagnostic efforts need to be directed at the underlying cause of MCI. That's really what's important. And I think there are two main issues here, sort of overarching issues. The first thing is that MCI cannot be judged alone by neuropsychological tests. They are, of course, important, but clinical judgment is really very important. And a second thing, and this is where I like to draw a parallel to real estate agents that often say that the most important thing when selling a property are three things: location, location, location. I think in neurology, the three most important things is history, history, history. So what is the history of the patient? So the first thing we need to know is what is the change in in cognition that the patient is experiencing. And of course, as with patients with dementia, it's also important to hear from the caregiver. But what we want to know is, when did it start? What has the cause of the symptoms been? Has there been progression? What is the disease trajectory? So is this has the cognitive problems progressed for a couple of months and then they have been stable for a certain period of time, or has it been a slow progression of the cognitive impairment? And I think also we need to know, what are the cognitive problems? Is it a memory problem? Is it an attention problem? Is it a language problem? And I think it's really important to solicit examples. So ask about specific examples. So if you have a conversation and some time has elapsed, do you remember what was said, or are you sometimes in doubt? Do you remember names? Do you need to use a shopping list? Are you able to concentrate on reading books and so forth? We also need to ascertain whether there has been any change in activities of daily living. And again, I think it's important to solicit examples. And when we are in the mild cognitive impairment range and we need to differentiate between early dementia, we really need to be asking about subtle changes, but also changes in more difficult aspects of activities of daily living, instrumental activities of living, such as finances, hobbies, using mobile phones, using computers. And if the patient, which is more often than in patients with dementia, is still employed, has there been any mistakes at the job? Has the patient received any reprimands? It's important to ask about psychiatric symptoms, especially depressive symptoms, which is a very often occurring differential diagnosis to the underlying cause of MCI. Ask about neurological symptoms. For example, paresis, sleep disorder, Parkinsonism, signs of motor neuron disease. Substance and alcohol abuse, also important, especially alcohol abuse, might also be an underlying cause of MCI. And finally, of course, the medical history, including medication use. Are there any anticholinergic drugs being used, morphine, benzodiazepines, and so forth? Then, of course, a physical and neurological exam is important, and use of a cognitive scale, a simple screening scale, perhaps, the MMC or the MoCA. And I would also recommend an ADL scale to document that ADL function is not reduced. And of course, some screening blood tests to rule out vitamin deficiency, thyroid disease, kidney and liver disease. At this point, in many patients, the clinician will be able to determine whether this patient might have MCI. And I think there's a couple of important points to be made here. So in the criteria for MCI and dementia, we talk about cognitive domains, but this is really something that there's no real consensus about what exactly a cognitive domain is, such as, for example, memory. So if we say that the memory domain is impaired, do we need to have a test of both verbal and non-verbal memory? And how many tests do we need to have to make sure that a cognitive domain is impaired? So I think here's an assignment. Here's something that the physician needs to make up his mind about. If he is convinced that for a certain domain the patient is impaired, and of course we can ascertain this by various measures. We can use some sort of psychometric cutoff scores. We can use our careful interview with the subject as well as the informant, or a combination of both. So, as I said, by now, the clinician should have a good idea about whether the patient might have MCI or not. So I think if the patient does not have MCI, we can reassure the patient and the family. I would consider reassessment in 6 months to make sure that the patient has not progressed to MCI. But this will, of course, depend on local organization. If the patient has MCI, then we need to decide whether we are able to diagnose the underlying cause with a satisfactory accuracy. And if that is the case, then we can inform the patient and family and institute therapy and arrange appropriate follow-up. If not, of course, we need to do ancillary investigation. And these might include a number of investigations, such as comprehensive neuropsychological assessment carried out by a neuropsychologist, MRI or CT, FDG PET, DAT scan, amyloid imaging, and tau imaging, depending on what your suspicion is of the underlying cause. And you will hear a lot more in the following 3 lectures about these ancillary investigations. Now, there are a number of issues relating to diagnosing mild cognitive impairment that gives rise to some problems and issues when one has to deal with mild cognitive impairment in the clinical practice. So, as I discussed earlier, to diagnose mild cognitive impairment, there needs to be a cognitive complaint, and this might come from the patient, or the caregiver, or a doctor or a nurse, or someone else who knows the patient. And this is usually not that big of a problem. Of course, sometimes you come across patients that have a difficulty explaining what the symptoms are, what he or she feels, or you might not have that good a rapport with the patient. But the real big issues is when we need to establish whether there has been a cognitive decline, an objective and measurable cognitive decline, and how much that cognitive decline needs to be before we can say that the patient has MCI. So how to document cognitive decline? Does it need to be a comparison to prior testing, or as judged according to norms and cognitive tests? And then how many standard deviations does the patient need to score below? What is a domain, and how do we establish impairment on a domain? So it's rare to have results from prior testing, but sometimes, of course, one is lucky, and there is the patient has been tested prior. With regards to norms, these vary considerably whether they are available. And they also vary from country to country and from language to language. And what factors need to be taken into consideration for these norms? So are these age adjusted norms, or do we also need to take sex into consideration, or education? And what about cultural appropriateness, something that we know from a lot of research is very important in neuropsychological testing. Then there's the issue of defining a domain, and I've already touched upon this. When I talk to my colleagues that are neuropsychologists, it is very difficult to find any consensus about what they think a domain is. And then there's impairment on a domain. Again, do we use psychometric cutoffs, and how many tests do we need to know? I touched upon this earlier on. And I don't really have any solutions to these problems necessarily, but I think a pragmatic approach in the clinic is always very good. If you have norms for tests, that's good. If not, then clinical judgment is of course paramount. What do you expect? How do you expect the patient to perform on the MMSE or the ADAS-Cog or the MoCA or whatever test you're using when you consider this patient's background with regards to education, culture, language, etc., etc. So I think this is the end of my talk. I'd just like to give a summary. And I'd just like to try to really underscore why we need to diagnose mild cognitive impairment, because I think this is an important thing to do, and I think it is a useful term, but we need to take some things into consideration. So, at least in my clinical practice, I see quite a lot of patients who do not have dementia, but clearly have suffered some sort of cognitive decline from previous levels, and it's clearly not due to aging alone. So I think mild cognitive impairment for me as a doctor makes a lot of sense. And I think that although the concept of MCI is very difficult to convey to patients, I think it's important to acknowledge that these patients are feeling something and they want answers. It's very important to keep in mind that mild cognitive impairment is a syndrome. It's not a disease. So as I mentioned many times, our job is only half done when we've confirmed that the patient has cognitive impairment. We really need to look at what the underlying cause of the mild cognitive impairment is. We need to be diligent, and we need to examine these patients carefully. And this is, of course, because in some instances, these the underlying cause of the impairment is treatable. It might be depression, thyroid disease, vitamin deficiency, it might be a tumor. So that's why it's important also. So moving on maybe a bit more to the neurodegenerative side of mild cognitive impairment, I think that, and many will probably agree with me that defining a pre-dementia stage of AD and other progressive neurodegenerative dementias vastly improves the disease model. It aligns better with our understanding of the biology of the disease, of the pathophysiology of the disease, that these are diseases that develop over many years, and that the patient goes from an asymptomatic phase with brain pathology through a period of progressive cognitive impairment, which dementia is simply the end stage of. And of course, we need to be able to diagnose these pre-dementia stages in order to carry out research. We need to have some common frame of understanding in order to be able to discuss these patients. And I think also that it makes a lot of sense that if we have a disease-modifying therapy for a neurodegenerative disorder, and hopefully we will soon have one for AD, these are bound to work better the earlier the treatment is instituted, because we are not at the present moment able to induce regeneration of neurons, so we need to stop the destruction of those neurons that are there. And as I said earlier on as well, patients with mild symptoms with ADE in early stages have a high wish to participate in research, and we should, and of course, diagnosing the disorder is necessary for them to enter in these studies. I think also another important issue is that AD and other neurodegenerative disorders, it's not curable. We do not have disease-modifying therapy, but they are manageable. We can manage risk factors. We can manage vascular risk factors, other risk factors. We can manage depression, other behavioral changes, epilepsy, seizures, etc. And we should not underplay this role in these patients as physicians. And treatment of AD, even in the pre-dementia stage, also encompasses support and non-pharmacological management, advanced directives, support groups, education of the patients and care. We need to empower these patients to make lifestyle changes. And if a patient seeks out medical attention, it's because they want to know what's going on. Pre- and post-biomarker counseling is key. Thank you for your attention. Okay, so that concludes my lecture here at the teaching course. And I will open the floor for any questions that you might have for me on this talk. So I just see that there is one question from Dr. Sai, who asks, why does cognitive impairment occur? Well, that's, of course, the whole point of the exercise of diagnosing these patients who have mild cognitive impairment, because we need to find out what the underlying cause is of their complaints. And I also see a second question, and that is from Giovanni. What is the prognostic in a patient who has mild cognitive impairment on a vascular basis, I think, was the question. And yeah, that's a good question. So in my opinion, vascular lesions might cause neurodegeneration, but that's not the real, the prevalent disease mechanism. It is these vascular lesions. And if you have, let's say strategic infarct, dementia, or MCI, we might call it, then your prognosis might be fairly good, because it might depend upon whether or not you get a new stroke. But if you have small vessel disease, then the patient is perhaps more likely to progress. But I really, I'm not sure that there are any real good studies out there showing what the or showing algorithms for individual patient prognosis in patients with mild cognitive with the vascular cognitive impairment. So there was a question on supplements for MCI and also on treatment of MCI. I think I can't quite see the questions. Can you help me, Mike, perhaps? How do I?
Yeah, you should see them in your speakers view on the bottom right.
Yeah.
In the browser. Yeah.
Okay. Now. So there was a couple of questions on treatment. So in my own practice, I sometimes start patients who I think have MCI due to AD on cholinesterase inhibitors. It is not approved for this indication in Denmark, and I'm not sure it is anywhere in Europe. So that's really very much on an individual basis, and I do not start all patients on cholinesterase inhibitors. And that was also a question from Sumit. And I'm having problems seeing the questions.
I'm going to send you the link again.
Yeah, it might have something to do with my screen.
Okay.
From Sumit, the question was, what is your view on the role of acetylcholinesterase inhibitors and Suvanate?
Yeah, so basically, as I said, once in a while I do start my patients who have MCI on due to AD on cholinesterase inhibitors, but far from all patients that I have. As I said, it's not approved for this indication. So you need to have a good conversation with your patients if you start them on this. Then there's a question from Jacqueline on is there any guide or advice for pre and post biomarker counseling in MCI? And at present, to my knowledge, there are no published guidelines or position papers on this issue, but it's one that I think is very important because we are really potentially imposing some difficult knowledge on patients with MCI if we're doing biomarker counseling, biomarkers in these patients. So we need to counsel them before we do the biomarkers, and we also need to do good post-biomarker counseling and explain to them what these biomarkers are saying about their risk of progression. So I don't know how much more time we have for Q&A.
1 more minute.
A minute?
Yes.
Okay. So there's a question from Maria. I think that the most important criteria for diagnosing MCI. So this is about using skills from other countries and cultures. Yes, I think that even for English-speaking languages where there are more norms, it is still difficult to use norms, and they are not very prevalent. So I think again it comes down to the judgment of the clinician. What is the expectation from based on the patient's background with regards to education and gender and so forth, with regards to what you might think is within a normal range for a given patient on a given test. Okay, so I think that concludes the Q&A for my talk, and I think we should proceed to the next speaker, who is Professor Jonathan Schott. Professor Schott is a professor of neurology at the UCL Queen's Care Institute of Neurology, and he also runs a multidisciplinary cognitive disorders clinic as part of the Integrated Cognitive Disorders Service at Queen's Square, and he has published more than 200 papers on a wide range of topics, and he has also co-edited the Oxford textbook of cognitive neurology and dementia, and therefore I think he's a very good candidate to give the next talk on the neuropsychological evaluation of early dementia and mild cognitive impairment. So go ahead and start the presentation.